Okay. Hi, my name is Barbara, and what you just heard is my husband Jim vocalizing. The tape is actually 4 segments. I taped over a 3-hour time period between 3 and 6 a.m. a recent morning. I can't absolutely, certainly translate what he was communicating, but at this point I think I can guess. And the first 2 segments, I think he was hallucinating. There were a good many hand gestures going with it, and he wasn't at all frightened. He was just engaged in what he was doing. The sounds were part of that. The last 2 segments were closer to 6 o'clock in the morning, and I think what he was doing was saying, "Would you get up? It's time to get up." And this is the way we communicate. Jim was originally diagnosed with vascular dementia about 7 years ago with an Alzheimer's component. And then 4 years ago, he had a bad fall and a long hospitalization, and they added frontotemporal dementia to it. But that fall changed him from a man who was working hard at trying to deal with the changes in his life that the disease was causing into someone who was terrified, angry, compulsive, and aggressive. He lost his ability to express himself in words and resorted to the kinds of sounds you just heard on the tape. It became unsafe to keep him at home, and he was placed in 2 different memory care units where the aggression was such a problem we were asked to leave. With luck and help from an agency, I was able to find a board and care that was willing to work with him, and with time and help and advice from his doctors, we found the magic cocktail that calmed him down enough so that I could bring him home. I brought him home about 2.5 years ago. Dealing with Alzheimer's has been a difficult challenge. Just when I think I have it figured out, things change and new behaviors pop up. I have a reminder on my desk. It says, "Soon, when all is well, you're going to look back on this period of your life and be glad you never gave up."
We are very fortunate that Dr. David Sultzer has agreed to come and lead us through this difficult topic. Dr. Sultzer did his medical training at the University of North Carolina before doing an internship and residency at UCLA. He did a fellowship in neurobehavior at UCLA. He's now a professor in residence of psychiatry and biobehavioral sciences at UCLA and the director of the Geriatric Psychiatry Fellowship at the West LA VA training program. He was one of the leaders and investigators in the clinical antipsychotic trials of intervention effectiveness, or CATIE-AD trials. Thank you, Dr. Sultzer.
Great, thanks, Josh. Good morning, everybody. It's a pleasure to be here. Wow, I am so impressed by Barbara. I think that video captures, all the videos today have been spectacular thus far, but that one, really captures the complexity, the humanness, the challenges of these symptoms in Alzheimer's disease. I mean, how many among us could truly, between 3 in the morning and 6 in the morning, tolerate that with great grace and dignity? It's truly impressive. We're talking about difficult behaviors and the complexities of management now, but this is a reminder about how gracefully it can be done. I'm just impressed with the poise, as well as Barbara's impressive ability to conceptualize the meaning of the symptom, thinking through why might he be doing it, and expressing just the normal human need to communicate with someone who doesn't have words any longer. And I highlight that because that's the first step in really understanding how best to manage symptoms like that. Does that person need antipsychotic medications? Probably not. The intervention is really going to be focused on understanding the meaning and trying to find other ways of helping him express that, or other ways of just coping with the repetitive behavior. So in the time remaining, and I realize that I have been, speaking of grace, being given a slot that is between a talk on sex and lunch. Thanks, Josh. Appreciate it. Back at you, dude. I've had some tough scheduling things to accommodate, but this could be a top one. But I'm up for it. Hopefully you are too. So I'm going to spend a few minutes talking about psychiatric symptoms, behavioral symptoms in Alzheimer's disease and other dementias. I'm going to highlight kind of two concepts, really. One is how we conceptualize these symptoms and how do we think about them, because I really think that helps us understand what's going on and how best to approach them. And then the second concept is to think about how we manage them clinically, at home, skilled nursing, medications, et cetera. Dr. Alzheimer, a psychiatrist in Germany, was well aware of the non-cognitive symptoms of Alzheimer's disease. His buddy Emil Kraepelin is shown there next to him. It was an interesting time in neuropsychiatry and at that time in Germany. His index case, Frau August, had early onset Alzheimer's disease. He identified the neuritic plaques at autopsy. But in his clinical notes, to line up with the video we just saw, in contrast to the kind presentation in the video, Dr. Alzheimer described in his notes, "Often she screams for many hours in a horrible voice." I think it highlights for me two things. One is the complexity of these symptoms, but also the fact that this is a fundamental part of the degenerative illness, unfortunately, that these things are part of the illness expression and we need to be thinking about them that way. These neuropsychiatric symptoms have consequences. They are many, and you can easily consider them. Things that come to mind recently are the impact they have on caregiver burden, that the psychiatric symptoms really drive much of the caregiver distress experienced. If you have a kind partner, you can do well with no memory at all. But when you're agitated, physically aggressive, and having disruptive behaviors, it's a whole different story. So it's really a key part of the morbidity of the illness. Some recent evidence on increased healthcare and utilization, costs and utilization, that this bar graphs here show some data that's going to come out next month in American Journal of Geriatric Psychiatry, highlighting that if you look at people with Alzheimer's disease and their spouse caregivers are either not distressed, low distressed, or high distressed, just crudely stratifying, that it triples the likelihood of emergency room visit over the next 6 months, year. It nearly triples the number of acute hospitalizations, and it doubles the Medicare costs. So when you start at a baseline in this population, roughly $20,000 a year for healthcare costs through Medicare, add double that because of behavioral problems, so that not only are these clinically important and societally demanding, but also from the point of view of healthcare costs. Some work we've done and others, and this kind of is making the point that these psychiatric symptoms are really fundamental expressions of the degenerative process. It's not really what old people with broken brains kind of act funny. There's much greater specificity to it than that. Different dementia syndromes have different patterns or spectra of non-cognitive symptoms. Some work with brain imaging, genetics in humans, mice, have demonstrated specific biological components that drive the psychiatric symptoms, a variety of them. The top left, delusions in Alzheimer's disease with a relationship with metabolic activity in their cortex. Aggression in transgenic Alzheimer's mice are more common. Aggression is more common than wild type. And some work we've done using a cholinergic receptor ligand, recognizing that there are particular parts of the brain that have a more advanced cholinergic deficit that appear to drive agitated behavior. So it's the biology talking, if you will. That said, all these behaviors happen in a context, and we'll be spending a lot of time talking about that. But just at this point, understand it's truly part of the illness itself. I'll go through several different kinds of neuropsychiatric symptoms and just hit the high points, and we can talk in the discussion about others you may be interested in. One is psychosis. Psychosis is delusions or hallucinations. Delusions are more common than hallucinations in Alzheimer's disease. There are particular themes to these false beliefs. There's always a challenge in distinguishing a delusion from a memory deficit. If someone believes that they're getting up in the morning and going to work when they've been retired for 20 years, by definition, that's a false belief and a delusion, but it's part of the memory construct. So we really are trying to think about what is something that's more ingrained, a false belief that's persistent over time and promoting disability. Interestingly, some work has shown that those Alzheimer's people with delusions have, unfortunately, a more rapid course of cognitive decline, that delusional thoughts are a poor prognostic indicator for memory change over time. So it's again part of this syndrome and cognitive process that is unfolding, and the delusions and memory things are linked. Medications are rarely used for delusional thoughts in Alzheimer's disease or hallucinations, partly because they don't work very well, partly because there's side effects, and we're going to talk about antipsychotic meds in a few minutes in more detail. But in general, we're just really mostly providing reassurance and support that false beliefs are fine unless they cause a lot of distress for the person, because feeling that people are intruders in the home, for example, that's a disturbing thought to have in an ongoing way. Or if the delusional thoughts or hallucinations substantially impact behavior so that people are responding to that and act in response physically, aggressively, for example. A couple circumstances in which we think a little bit more broadly about psychosis in cognitive disorders. One is Lewy body dementia. Visual hallucinations are actually part of Lewy body dementia. 80% of Lewy body dementia people have visual hallucinations. Parkinson's disease, similarly, the prevalence of visual hallucinations is quite high, often related to dopamine replacement therapy, but also related to the illness. James Parkinson acknowledged that there were misperceptions among people well before we had Cinemet. So there's evidence that it's actually part of the disease process again. In these symptoms, we try again to avoid pharmacologic intervention, that if meds are necessary for Parkinson's disease, for example, we consider an atypical antipsychotic such as quetiapine. There's actually very little evidence that quetiapine works. There's not evidence that it doesn't work, but it's not a particularly evidence-based practice. Pimavanserin is a new medication that's been FDA approved for Parkinson's disease with psychosis. And clozapine, a more complicated drug to use, mostly by psychiatrists, but actually has the best track record for efficacy in this circumstance. Agitation, a broader constellation of symptoms, and the term has been used earlier today and will permeate today's discussions, I'm sure. It's really hard to know what agitation is. In my teaching and training with doctors in training, I refer to agitation as really nothing more for most than unlikable behaviors. And when you try and think about what's the best way of managing unlikable behaviors, Dr. Sultzer, which medicine is best? Beats me. I mean, it depends on what they're doing. It's just the context of it, and a real challenge for the field and all of us who work or with family members is to really understand what we mean by the behavior and refine that term. That if we're left with looking for, the FDA has wrestled with this, would they label a medication for agitation? Their main concern actually is we're not too sure we know what you're treating, and it's an important concern. My belief is that can be refined and not with a lot of difficulty. It's just, it hasn't happened yet. Prevalence is common, these agitated behaviors, and you can categorize them, for example, as non-aggressive physical behaviors such as pacing, aggressive wandering, physically aggressive behaviors, or verbal behaviors, just to kind of provide some crude categories for things. They're common, they occur more frequently in late stages of most dementia syndromes, including Alzheimer's disease. They too are associated with a poor prognosis over time. So how do we approach these? I think my entire remarks here this morning, this is probably the most important slide, to be thinking about first of what's the behavior. Okay, it's agitation, but what really is going on? To be able to have an opportunity, particularly in busy clinical settings, to talk to the patient and the carers about what specifically is going on, to understand the context of the behaviors. What happened before he got upset and hit somebody? What are the spectrum of behaviors? Is there anxiety or mood symptoms associated with it or other things going on? Secondly, are there medical contributors to this? That if you had advanced dementia and couldn't express yourself clearly and had urinary retention because your thoughtful clinician had just started you on a potently anticholinergic medication and you couldn't urinate, that reaching out for people in a skilled nursing facility would be called agitation, but it's an attempt to communicate a need and to be thinking, the first thing we think about is what medication did someone just get started on recently and which of their 27 other medicines might we want to be able to dial back. Are there other contributors? And we could spend the entire session talking about this, but when there's too much or too little stimulation, people may do poorly. They fill the vacuum of boredom with activity that may be troublesome. They misinterpret things, and that has an impact on their ability to respond appropriately. There are environmental factors in skilled nursing homes, for example. The noise level can be just extraordinarily high. Many people have difficulty hearing. The TV is turned up really loud. The loudspeaker system that has the lowest quality audio system available is saying, I mean, that's the environment people are sitting in, and we're asking them to behave normally. That's an unreasonable request in my mind. And then what's the acute risk? And this is important because as we move toward from assessment to understanding how we might suggest intervening, it's going to include the role that safety measures play if symptoms are severe. The use of psychotropic medicines is going to be largely driven by the risk-benefit ratio, and to understand what the benefit is, to know what the risk is that you're trying to improve is important. Psychosocial interventions or non-pharmacological interventions or behavioral interventions are a constellation of approaches that are used first line to manage most neuropsychiatric symptoms, and particularly agitation. They're targeted towards the caregiver, patient, or environment, or all of the above. And this is kind of a nerdy science list of these things. The implementation of these things is much more complicated. Again, a whole nother session could be done with caregiver interventions. But the focus is really two things working with caregivers. One is helping them problem solve, to avoid the triggers, to reassure people who are upset about something. Dementia patients are surprisingly sensitive to social cues. People in skilled nursing facilities or at home with advanced dementia may not recognize family members, may have great difficulty understanding words, but boy, they can identify an upset caregiver like that. And the affect in the room is far more important than the words. So for example, managing the affect and just the comfort level and the kindness that the person who's distressed with dementia is seeing is a key part of management. Working with caregivers about what they can and what they can't do and let it go. It's extremely difficult to work with folks at home who have agitated behaviors intermittently. They can be unpredictable, and just to be able to kind of have the support that they need, obviously. And then to work with emotion-focused approaches, support, time for themselves. Roughly 40% of home caregivers have clinically significant depression or anxiety themselves, which probably exceeds the prevalence of those symptoms in the person with Alzheimer's disease broadly. So we're targeting the patient, but actually the caregiver can often benefit from at least consideration of these issues, obviously. Medications for agitation and aggression. This panel shows a variety of different meds that have considered over the years. We'll speak to antipsychotics in a moment. Treatments for Alzheimer's disease, such as cholinesterase inhibitors, donepezil, rivastigmine, galantamine, or memantine, are found in general in large samples to have some benefit for people usually who don't have symptoms of agitation at the beginning of their treatment trial. They have less emergence over time, and that's considered benefit. In contrast, studies that have looked at using these medications in somebody who's acutely agitated, they don't work very well. So we have some optimism about these medicines, cholinesterase inhibitors or memantine, but yet we're not particularly optimistic about their enduring effects, or acute effects actually, at the moment. Anticonvulsants have been used. The track record is not great there, and side effects tend to be problematic. Serotonergic medications that include trazodone and citalopram, I'll talk about in a minute, and some other medications. And there are a number of meds that are non-antipsychotics that are now getting a lot more attention and we'll likely hear more about in the future. This slide you can't see from where you're at, and that's a good thing. This is from a meta-analysis I work with RAND Corporation. We published in JAMA a few years ago, looking at all the trials of atypical antipsychotics for agitation in Alzheimer's disease. And what it shows is if you look at the 4 most commonly prescribed atypical antipsychotics, and in the treatment trials, the red line up and down in the middle is if the trial showed that there's no difference between placebo, an inactive treatment, or the active treatment, which was the antipsychotic on the left. So if that red circle's in the middle line, there's no difference. If the circle's to the right of the line, it indicates that the active treatment was better than placebo. And what you see here is that the red circles, by and large, are to the right of that line, but the magnitude, and you can't see the scale at the bottom, but is relatively small. So on average, the magnitude of benefit of antipsychotics is real, but it's small. You'll also notice that the one that doesn't get too far to the right is quetiapine, which in my experience is now the most frequently prescribed antipsychotic for behavioral problems. The evidence supporting that is thin, and so it's a reminder that we live in pharmacotherapy cultures, and belief has a lot to do with things. So it may be that quetiapine is helpful for some folks, but the evidence doesn't support that as well as others. We're also looking at relative sensitivity to particular side effects in our thinking, so choosing a medicine that has the most benign side effect profile for the person that we're treating. Interestingly, just I forgot to mention the effect size for psychosis. Antipsychotics are not very good for psychosis in Alzheimer's disease. So if you had a choice of thinking, would antipsychotics be better for psychosis or agitation, you would think psychosis because they're antipsychotics. The patients don't read the pharmacology textbooks or our thoughtful expert opinions that actually agitation, statistically, which is kind of a nerdy way of thinking about it, but on average, the benefit on behavior may be greater than that for psychosis. Medicines have side effects. All medicines have side effects, antipsychotics in particular. There are the usual suspects on the left-hand column, but in this population include additional cognitive impairment, which is obviously something we want to avoid. A colleague of mine pointed out that on average, the cognitive decline that one experiences with Alzheimer's disease treated with an antipsychotic is just about the same as the cognitive benefit on average that you get with a cholinesterase inhibitor. So we're essentially undoing the cognitive benefit of cholinesterase inhibitors. That said, I mean, there is benefit there, and I realize I'm painting a negative picture, and I think I most accurately want to paint a cautious picture. Among the medications on the slide I showed previously, the best evidence for efficacy is with antipsychotic medications. So they continue to be considered first line, should medication intervention be required. It's just we've learned over the last decade that their benefit is smallish on average, but in practice we're seeing an individual person. So that person may or may not benefit as much as the average, and we need to keep that in mind. There's also a signal for mortality. We could spend a long time talking about how that was discovered and how regulatory systems work. But the main point here is that there is a signal, there's a risk for increased mortality, death, among people taking atypical antipsychotics. The magnitude of that is small, but because it's death, that's something you're obviously concerned about. And what I'm surprised is a lot of the trials show that the likelihood of death in these populations in the placebo-treated group is quite high, reminding me the context that we're working here. Many of these folks, the trials of antipsychotics, the mean mini-mental state score was 11. So these are folks who have severe Alzheimer's disease. If antipsychotics may be helpful but are often harmful, can we better apply them? Can we bring the point I made earlier about definition of agitation and the modest benefit of antipsychotics together, are there particular agitated symptoms that respond better, just to raise the likelihood of success and expose people to medications that could be harmful with the greatest likelihood of success and outweighing that risk. Some work we did with the Katie study as a post hoc analysis was to look at that. And to make a long story short, the atypical antipsychotics seem to be preferentially beneficial for the angry, hostile, mean, and paranoid symptoms that people exhibited. Other kinds of agitation, either verbal behaviors or the non-aggressive or less aggressive physical behaviors, specifically the antsy, agitated pacing, motorically activated behaviors, didn't respond as well. So the field, and I think this is now percolating into the trials to try and understand which of these symptoms get more better with the treatments we currently have available. Other molecules are being explored to get away from the antipsychotic approach. There was a trial of Citalopram, which is an SSRI antidepressant that was completed a few years ago, but showed very good benefit in a solid treatment study, modest sample size, 9 weeks of treatment. Essentially 40% of the people treated with citalopram, the active drug, over 9 weeks were considered moderate or markedly improved, whereas 20-some% of those with placebo. So that's a big effect size. Unfortunately, during the time of that trial, there was increasing awareness that citalopram can cause some cardiac conduction problems, QT interval prolongation. The target dose in this trial was a dose that we probably shouldn't be treating everybody with because of this newly appreciated risk. So it's an example about the good news is it worked. It's not an antipsychotic. The bad news is we probably can't use the doses that are being prescribed and that were prescribed in this study. But the other good news is that's now being kind of repurposed in an additional trial looking at the enantiomer of citalopram that has the beneficial effects and avoids the side effects. So we'll be learning more about that in the future. There are a lot of treatment trials going on right now. It's a very rich environment for development for obvious reasons. It includes thoughtful studies of behavioral interventions, understanding how best to apply behavioral interventions in different settings, that we can have these complex ideas about what works as far as psychosocial strategies, but if it's not practical, if it's not efficient, if it can't be done relatively quickly, it won't be of value because we need to have stuff that is available for all to use in many settings. And that the field has really been better able to focus on that now. Other medications, a variety of molecules listed here. Everything here is in phase 3 clinical trials. So we'll be learning more with large samples, so we'll be learning more. A couple comments about that heads towards the future. One is this issue about how do we implement these things? And an inspired study that Clive Ballard did in the United Kingdom was looking at the WELD program, and this was in skilled nursing facilities. And in brief, there's a lot of information on this slide, but the bottom line is that in a very naturalistic and patient-centered way, had 3 different strategies. One is we're going to try and reduce their antipsychotic medications if possible, but with no required mandated approach to it. We're going to increase social interaction among the residents who have behavioral problems, and we're going to, try and have 3 days a week minimum, or many hours a week, I guess was the way it was set up, of increased social activities. And third, a modest exercise program. Simple, doable things in a skilled nursing home, and then followed people over 9 months to see how they did. The science of it was they applied these different strategies in different nursing homes in different ways and different combinations to kind of see what worked together. And it turned out that when they reviewed the antipsychotics, and this was not done by the physicians, it was done by care champions in the home, kind of hinting to the medical treatment team and nursing staff, maybe he doesn't need to be on the antipsychotics. It reduced antipsychotic prescription by 50%, just with hinting. And that, as not entirely surprised, the prevalence of behavioral things actually increased. So, that there were behavioral consequences, but that the behavioral consequences were overturned by those who had increased social interactions as well. So I bring it up as a kind of a pretty clever way of looking how we do business, how science works and how we measure these things and look at interventions. So the combination of these things are important and provide an opportunity to kind of apply the tools that we have in simpler ways. The Escitalopram study, I spoke about the citalopram and mentioned that this is another approach. And now I show it not so much for the pharmacology of it, but the design of this trial. There's investigator meeting was just last week it's a multi-center study sponsored by the NIA. And this study is designed so everybody who enrolls with agitation, mostly outpatients, has a 3-week psychosocial intervention period. So in the trial, that's part of the study itself. You don't get any medicines for 3 weeks. It's simple, it's patient-oriented, it's working directly with caregivers. And then if you continue to have behavioral problems at the end of 3 weeks, then you're randomized to drug or placebo. And all the groups are followed over the course of the study, including those who responded to the psychosocial intervention. So a different kind of way of looking at, it's not just taking a population with a particular problem, half get placebo, half get active drug to see what works. There's a role for that, for sure. But to try and embed these kind of truly effective and real-life approaches in the trials will give us information for the future that's much more applicable, I think. I'm going to run out of time, but just to make a couple comments about other symptoms. Apathy, sort of the anti-agitation, and you could kind of say, well, gee, who cares about apathy compared to physical aggression? It turns out that apathy is one of the earliest signs of Alzheimer's disease, probably. We've done some work in others identifying that older adults who have subjective memory complaints, if they have symptoms of apathy, are far more likely to progress to the clinical syndrome of Alzheimer's disease. And the sense is that apathy is really an early expression of neuritic plaques and tangles in your brain. So that we're kind of thinking about, again, these things as being part of the overall syndrome. It's also important because apathy is clinically meaningful to people and really has an impact on morbidity. It's not depression. And the management is predominantly stimulating activities, as well as the pharmacotherapy is still at an early phase. There are some strategies, but not usually used. Depression and anxiety, in brief, depression is a risk factor for Alzheimer's disease, and there's been a long-known, fascinating relationship between mood symptoms and Alzheimer's disease. Those who've had a history of major depression are at risk for Alzheimer's disease greater than those who haven't. And that in the slide shown here that you can't see again, but the point is anxiety raises the likelihood of your developing memory impairment if you've got amyloid in your brain based on imaging. So it's really an interplay or an emerging symptom at the same time. There's other symptoms that we can talk more about, but just to remind, as you're aware, that agitation is a large tent. There are resources available. I've listed some here that I think are particularly good for family members, for nurse caregivers, for nursing home staff. I chose ones, these are ones that are really kind of start with what a symptom is. So if a person is having a problem with delusions, there's a section on that, so it makes it a little bit more user-friendly, but feel free to check them out. So to wrap up, kind of think about the future, where are we now and headed to better define the syndromes, particularly agitation, to understand better how we can identify those who are going to be most affected in a beneficial way by psychosocial interventions and medication treatments, and which of those interventions work best for which symptoms. To consider, again, practical, effective, and safe management, to integrate these things, to have them be person-centered. These simpler trials that have shown benefit psychosocially, a key thing they share in common is identifying for that person how would things work in that caregiver. So to bring that kind of humanity as well as practical sense into how to think about and help guide the management of these symptoms. So I've spoken relatively quickly, and I am now approaching the lunch hour, which is a good time for all. So I'll stop here. I hope this has been helpful to you, and be happy to take some questions in the few minutes remaining.
raise the lights. Questions? Dilute those. There are.
I'm not sure this is the section to talk about it, but looking at the afternoon is probably the best place to put it in. But when you have this diagnosis, early on diagnosis, how do you deal with notifying friends and family that you have this diagnosis without the feeling that they're going to feel sorry for you? We know they'll support you, but how do you tell people, other than close family, that you have this diagnosis?
Tell people outsiders or tell the person?
Friends, family,
Yeah.
extended family, without, getting the feeling that they're going to feel sorry for you rather than, just kind of how do you deal with it? How do you say it? Just go say it? Or what do you do?
Yeah, I mean, we could spend an extraordinary amount of time discussing that. And the theme is, it just depends on the person and the circumstances. That a couple of pieces that I always consider is, the truth is usually a good thing. And that many times when people aren't being told, it's unfortunate because they sort of know already, and it undermines the ability to communicate, share, and support. So go for it. How you go for it depends on the circumstances, the culture, the feelings of the individual.
Especially for people that are important in your life, consider education. Consider utilizing the resources that are available to educate people about what it does and does not mean to have this diagnosis, and how it's not the end of life per se, and that people remain active and otherwise healthy and able to live full lives. I think that education may be critical to managing those relationships.
That's a great point.
I think there's hands.
Yeah.
I have a question. Oh.
Go ahead.
Okay, just do you know of anybody doing any studies on marijuana derivatives for treating agitated or anxiety patients?
Yeah, yes, there are studies ongoing. There has been 2 trials that I'm aware of, Brent Forrester at McLean and the Hopkins. Okay, a UK trial as well, I wasn't aware. That, and the 2 that I'm referring to have actually been completed, showing some benefit of either being applied usually as dronabinol, kind of the science form of the cannabinoids. There are now some new trials being developed to look at it further, including different ways of administering it. It has societal issues, it has legal issues, it's mostly stigmatizing issues, if that's the right word. So it's complicated. That said, the preliminary data suggests that it works pretty well. The question is who does it work for and how best to apply it? And there'll be a lot better data about that probably over the next couple of years. But in the meantime, and some people are, it's being done. It's probably not first line, and that's probably a good thing.
I have a question. My company works broadly in the community, and when we come across families who would benefit from these types of research studies, how do we identify those, and how do we help direct them to those programs so that we can, especially those that are lower income, that need more support, that don't have access to other greater resources, it would really be beneficial to help bring this type of support to them and get them directed and put into these types of programs.
No, absolutely. And from the point of view of support activities, just more broadly, the Alzheimer's Association, other groups do an excellent job of that. It's just helping guide that in that direction. When it comes to research participation, that many people like because it's doing something and engages. There's the opportunity to benefit, perhaps depending on the nature of the study. But the process of the study, many people find helpful. More specifically, Josh, do you want to address access to trials, either locally or more general?
Yeah, I mean, I think that those are all great points, and there are.
He does this all the time. That's why I'm.
There are ongoing trials all the time. We talked about some of the resources at UCI Mind and clinicaltrials.gov. I think visiting AOC's booth and AAOC's table for access to other support resources, and then I'll just say, In a moment, I'm going to ask everybody to advocate because families need more resources and government representatives need to know that. And so write a letter. Call your representative's office and say that we need more support resources for families in the throes of these diseases.
Do we have some sort of standard letter that we could access that would allow us to send that to, like maybe AOC can help us draft that letter?
Right back to that.
Beautiful.
There's some over there, looks like bottom left, yeah.
My husband has been diagnosed with mild cognitive decline. He has seen a neurologist, and he has been put on the standard medications for Alzheimer's. My question to you is, he's becoming more lethargic and depressed, and I wonder how you distinguish whether the medication is causing some of this or if this is a natural decline happening.
Yeah. Good question. I would start with understanding what the medications are he's being treated for, because it sounds like the timing is coincidental, so it makes you wonder if it's related as you're doing. Secondly, based on knowing what the medications are, we know kind of on average how often that happens. Things happen with psychotropic medications that we can never explain, so we have to have an open mind. That said, for example, cholinesterase inhibitors, donepezil, rivastigmine, galantamine, don't usually contribute to depression. That would be unusual. So that would lead me to thinking about other things. And those other things would include other medical things, what's going on medically in other ways, and environmentally and situationally. Are there things going on that are contributing to that experience that he's having? It may also be part of the illness itself that still responds to things that are around in the environment. So then be thinking, what's the best way of approaching that? Watch it over time, see what happens, tweak some current medications that he's on to see if that might be offending. For example, take him off a med to see if that improves. And then over time, consider other pharmaco or psychological therapies to see if that would benefit.
Hi.
Hi.
You mentioned depression, bipolar disorder, psychiatric disorder history can be predictive of greater risk. First of all, do we have developed subtypes of Alzheimer's based on symptoms? And if so, do the psychiatric issues point to a specific direction? Are those patients going to have more behavioral issues, more psychosis?
Yeah. It turns out that risk is real for those who've had depression. The people who were in that category who down the road develop Alzheimer's disease appear to have the same kind of Alzheimer's disease as the others. So it doesn't point towards a particular direction later. There is some evidence that it raises the likelihood of them having mood symptoms during the course of their Alzheimer's disease as well. And you'd expect that because they're predisposed to that and have had a previous history. So we're going to watch for that, but we don't usually see a separate kind of Alzheimer's disease. It's a good question. The other thing I'd put in there is we're talking a lot about Alzheimer's disease, that vascular dementia is another large category of dementias that isn't as well understood. We know that small vessel cerebrovascular disease that may seem clinically fairly benign actually leverages the neuropathology of Alzheimer's disease to promote greater cognitive difficulties. And I say that because those with cerebrovascular diseases, either strokes, but more often small vessel, chronic hypertension, diabetes, and the brain changes associated with that are much more susceptible to depression. So I think rather than thinking about their pre-morbid psychiatric history, it's their vascular history and be thinking about that as far as risk goes.
Sure. All right. Thank you, Dr.
Good.
Sultzer.